All right, let's get right into it. In trauma care, those first few moments are an absolute whirlwind, right? You're controlling massive bleeding, you're securing airways, you're trying to stabilize a patient who is right on the edge. But what happens after that initial storm passes? Well, that's when the real detective work begins, and that's called the secondary survey.
This question right here, this is everything. The primary survey, your ABCDEs, that's designed to find the things that will kill your patient in the next 5 to 10 minutes. But what about the injuries that'll kill them in the next few hours or cause a permanent disability? That's what this is all about. The secondary survey is our systematic hunt for those hidden injuries.
So here's our game plan. First, we'll nail down exactly what the secondary survey is. Then we'll talk about gathering intel with a great mnemonic, AMPLE. After that, we'll walk through the methodical head-to-toe exam, cover the neuroassessment, and wrap it all up with the final tests and treatments that complete the picture. Okay, let's get one thing straight right away. The secondary survey absolutely does not start until the primary survey is done, resuscitation is happening, and the patient's vital signs are starting to normalize. You gotta have the immediate fires put out before you start looking for smoldering embers.
Now look at the emphasis on that word all. If the primary survey is about spotting the tip of the iceberg, the secondary survey is the deep sea dive to map out everything, and I mean everything, lurking underneath. The goal is simple, but it is profound. Leave no injury undiscovered.
So where does this deep dive begin? You might think it's with some fancy scanner, but nope. It starts with a conversation. We gather our intelligence with a simple but incredibly powerful tool, the AMPLE history. This is often our first and best clue about what we should be looking for. And this breaks it down perfectly. Every letter here gives us info that directly impacts our next move. A for allergies? That's a no-brainer. We don't want to cause a whole new problem. But what about M for medications? Think about it. Is the patient on a beta blocker? Their heart rate might not go up even if they're bleeding out, which totally masks a classic sign of shock. P tells us what kind of shape they were in before the injury. L for last meal is crucial for anesthesia if they need to go to the OR. And E, the events of the injury, that tells us how they got hurt, which helps us predict the pattern of injuries.
Okay, now we get hands-on. This is a methodical, systematic examination of the entire body. And the key word here is consistency. You do it the same way every single time, so you don't miss anything when things get chaotic. And we always start at the top. The head and face are just packed with complex structures that can hide some really subtle but devastating injuries, so we give them our full attention first. We're using our eyes and our hands for everything. You've got to run your fingers through their hair. Do you feel a boggy spot, a step-off that screams depressed skull fracture? Check their vision early, before the swelling gets worse. And ask a simple question like, do your teeth line up right when you bite down? That one question can diagnose a nasty jaw fracture before you even get an X-ray.
From the head, we move methodically down to the neck. Now this is a small piece of real estate, but it contains the airway, the major blood vessels, and the spinal cord. An injury here can go south fast. All of our senses are on high alert here. We're feeling for tenderness over the spine, for sure, but we're also feeling for that weird, crackly sensation of subcutaneous emphysema. You know, like Rice Krispies under the skin? That's air leaking where it shouldn't be, a huge red flag for an airway or lung injury. We're watching for swelling and listening for bruits, that whooshing sound that could mean a major vascular injury.
Continuing our journey, we arrive at the chest. And remember, we already took care of the immediate life threats here during the primary survey. Now we're hunting for the more subtle stuff that can still be a killer.
So now we get really specific. We're running our hands over every single rib. And not just the front, the sides, the back, everything. Tenderness over the ribs on the lower left? That should make you immediately think about the spleen. When you listen to the heart, are the sounds kind of distant and muffled? That could be your first clue that a cardiac tamponade is developing. It's all about connecting these small findings to potentially huge problems.
Next up, the abdomen and pelvis. Now, this is a region that can hide a catastrophic amount of blood without any obvious signs on the outside, so our suspicion has to be through the roof.
Just looking can tell you a ton. That seatbelt sign across the abdomen, that's not just a bruise. That's a marker for a massive amount of force, and it makes you highly suspicious for an underlying bowel injury. And when you palpate, you're feeling for that involuntary guarding that just screams peritonitis. And please remember, this exam is not complete until you've checked the perineum, always with a chaperone present. We have to maintain our patient's dignity while providing top-notch care. All right, time for the arms, legs, and the part of the patient we haven't even seen yet, the back. It is so common for injuries to be missed back there, especially penetrating wounds. We can never, ever skip this step.
So every limb gets checked for deformity, stability, and this is critical, distal pulses, motor, and sensation. Then comes the log roll. This has to be a coordinated team effort to turn the patient safely so we can see and feel the entire length of their spine. Finding a wound or a tender spot back there can totally change the entire plan. Okay, so the physical exam gives us a map of the body's structures, but now we need to assess the function of the central computer, the brain and spinal cord.
And listen, this is not a one-and-done assessment. A trauma patient's neurological status can change in a heartbeat. If that GCS score drops, even by a point or two, that's a massive alarm bell telling you something bad is happening in their head. We are constantly reassessing, always looking for any change from their baseline. And this table might look intimidating, but it's really just a cheat sheet for a quick, focused assessment. We're not doing a full neurology consult here. It's simple stuff. Can a patient follow your finger with their eyes? Boom, you've just tested 3 cranial nerves. Ask them to smile or shrug their shoulders. With these simple commands, you're gathering absolutely critical data about their brain function. So, the hands-on exam is done, but the survey isn't over. We finish by thinking about adjuncts. These are the extra tests, the imaging, and the preventative treatments we need to get the full picture and make a solid plan.
Tetanus prophylaxis is a perfect example. While we're so focused on the big, life-threatening injuries, we can't forget to prevent problems down the road. As this table shows, you just need to know their vaccine history and the type of wound, and you've got a clear protocol to follow. It's a simple step that prevents a truly devastating disease. That's what comprehensive care is all about.
Let's end with this quote, because it just gets to the absolute heart of it. The secondary survey is the safety net of trauma management. It's that deliberate, meticulous process that stands between your patient and a missed, potentially catastrophic injury. It's not just a checklist, it's a philosophy of care. So the question this leaves us with is, in the controlled chaos of the trauma bay, how do we make sure we are always hunting and never, ever missing?